Yeah, that would be great. Yeah, good too. It's okay to, yeah, thank you. So, central PAs, obviously identify the spinous process. When you come up to the crest, most folks will say that this is the L4 region here. What happens if this is really L3? And I mobilize and I test it and it's hypomobile. Okay, so palpate. Here I think it's L4, but it's really L3. That's hypomobile. What are my consequences of being wrong? Nothing. That's a stiff segment. That's the one I'm going to mobilize anyways, right? Okay, so it's supposed to be L4 there. Whether it is, no big deal. Identify the segment. I'd like to take up a little bit of that skin tissue there. We'll call it Texas twist, right there. I do the Paul Revere riding the pony here. Right, so get the Paul Revere right up on the pony there. Here's your pony. Here, tissue tension there. I'm right over the spinous process. My sternum is directly over where I want to mobilize. I'm not back like this trying to mobilize. Take up tissue tension here. Assess quality of motion and quantity of motion. So I'm assessing how much it moves and the quality of that movement. Are you feeling anything at all here? Any change in your symptoms? Nothing. Up to the next segment. Here. Mobilizing. Are you feeling anything there? Oh yeah, I'm feeling a little bit. Patient tells you he's feeling a little bit. I'm like, okay, what are you feeling? You feeling? Are those the symptoms that brought you to see me, or is it something different? No, it just feels a little stiff. Okay, so I'll note that. It's got a little bit of stiffness here, but it's not reproducing those symptoms that brought him to see me today. So I need to keep looking, don't I? Here. Say I'm doing a central PA here. What are you feeling there? Oh, that's uncomfortable. Pain that brought you to see me today? Yeah, that's it. All right, so as I do this, what's the intensity of that pain on the 0 to 10 scale? 8? Oh, it's an 8. Okay, when I stop, what are you feeling? Oh, it still hurts. I can see his eyes are starting to sweat a little bit. Am I going to mobilize that segment there today? Okay, right? How intense is it? It's a 2. When I stop, what happens? Gone. Right? That's probably going to be an intervention I'm going to target today. Okay, so that's central. Unilateral. I like to find the SPs, slide just laterally. And I like to bring my fingers together and support them like this so that I'm not getting sloppy and hyperextended this way. And that's going to wear out my thumbs pretty quickly. Here. Slide the tissue just laterally here. Over those articular pillar. Over the articular pillar. Again, keeping my sternum above my mobilizing hand and assessing mobility here. Moving up to the next segment. Quantity, quality. What are you feeling there? Always communicating with that patient, right? What if he says, oh, that feels better? Also thinking this is probably an intervention for the first day. And so when I do this, I'm actually on the left articular process. So I'm on the SP and I slide this way. There. Forces, exactly, forces downward. You'll go to some courses where people say when you mobilize the spine, you have to do it exactly on the plane of the facet joints, and if you don't do it on the plane of the facet joints, not only is the patient going to not get better, but they're going to get worse. That's not the case. Okay, so don't become paralyzed by trying to do these complicated gymnastics in your head. Identify an asterisk sign, use your irritability, that's about a 2. Stop, gone. All right, I'm going to work that a little bit. I'm going to get in there and work that. 0 to 10 scale now. What's the intensity? Oh, it's still at a 2. Okay, I'm going to keep working that. Another maybe 30 to 60 second bouts. Or you might go to another segment. Is that reproducing your symptoms? No, but it feels a little stiff. Okay, I want to get in there and work that. So I might do 3 or 4 levels, get them back up, reassess the asterisk sign. It's better.
Is there any dosage is there? Like any dosage?
Yeah, so typically what they say, studies haven't been done to say this is absolutely the length of time you should do it. But I usually do studies have done 2 to 3, 30 to 60 second bouts. I'm closer in the clinical practice to 60 seconds. And then I'll do 2 to 3 bouts of that in that particular region with, say, a minute break in between. And then maybe move to another segment. Now, if I get in there and I do 1 bout and he tells me his pain's up to a 6 now, I'm not going to do the 2 extra bouts. I'm going to move on.
So can we do with the hypothetical part of the answers? Because if we do this for a prolonged time, for 1 minute, then even we can have a pain.
Yeah, and that's why I'm cautious to not do this. I personally, certainly, I mean, there are probably 20 different hand positions. People will tell you need to do it a certain way. I don't believe that either. There are probably a number of different ways you can get in there and move that. And just based on who you are and your body size, your body type, your hand type, the mobility in your thumbs, that's going to make it, you need to find another alternative route to do that. But whatever you do and get over those articular pillars with a proper hand technique, and some folks I've seen even do this and do bilateral and here, and just use their 2 fingers as dummy fingers and perform the mobilization through the left hand. And so whatever works for you, as long as you're getting the mobilization there, and testing, intervention, retest. So that's important to keep in mind. Thanks, Chris. So let's go ahead and run through